formally begin our event, which I want to do by first welcoming you and thanking you for participating, those of you who are participants, and especially thank our our attendees who are here to join us in speaking about what you're doing in the regions, as regional chairs of ISSBD, of IAGG, or their representatives in some cases, and also how we're going to move forward as we think about the decade of healthy aging. All of you are distinguished members of the gerontological and geriatric community, and so I'm delighted that you have accepted our invitation to do this. One of the advantages of COVID, the very few that we can find, is that we are able to do this with everybody in their home environments or wherever they're choosing to be at the moment. And we are therefore getting both wonderful participation from our panelists, but also from attendees who, just looking at the list, I can see are all over the world. I want to tell you a little bit about how we're going to manage this event. I've asked each of the regional chairs to speak for 10 to 15 minutes and to discuss both what's going on in their region and how they see us moving forward, especially addressing the issues of the decade of healthy aging, not to mention the incredible challenges we are facing and older people are facing in particular. I will call on each of you in the order that you're in this flyer that you see, which is a little bit different from the bios, but if you want to see a little bit more about each of our speakers, you should have the bios, and if not, Erin, I think we'll put it in the link to it in the chat as soon as she's able. After the speakers, we will have an opportunity for the attendees to comment, to ask questions, and to engage with the speakers, or to make any point they'd like to make to follow up on the points that the speakers have made. So we begin, I guess I should have introduced myself. We go now to introductions, so I guess I'll start with introducing myself. I'm Toni ANTONUCCI, and I speak to you in the capacity of Secretary General of IAGG, but also as head of the UN team. We maintain a rather active membership and involvement in the United Nations, and this IDOP, International Day of the Older Person, is essentially a United Nations event. They have made it an opportunity to really highlight both the contributions and needs of the elderly, and I've been privileged to be involved with it, I think, from the very beginning. And it is often, especially in the early years when we were there in person, it was often introduced by the Secretary General of the United States, of the United Nations, which is why, I think, a wonderful recognition of their recognition of the role of older people and the importance of older people and the needs of older people. So that's a bit about IDOP and just a little bit about me. I am happy to introduce Dr. John ROWE, who is the president of IAGG, and will give us some introductory comments to frame this event. Jack, take it away.
Thank you, Toni, and congratulations on putting this together. I'm delighted to participate. I'm delighted to see we have such a strong audience. I want to also congratulate Martha Beil, who is part of the IAGG UN team and who was co-chair of the events earlier today celebrating the 30th annual UN International Day of Older Persons. I'll just make some table setting remarks. Hold on, I have some noise in the background here, so hold on.
That's the world we're living in. Adjustments. You are all the panelists. You're on mute.
Just had a package delivered here. So the decade of healthy aging, which is a very exciting opportunity for us, obviously, has come about through the very hard work of the WHO team, including John Beard and his colleagues over the course of several years. And it was particularly noteworthy that it was endorsed in August by the World Health Assembly. As you probably all know, the Decade of Healthy Aging has basically 4 specific goals. One is to change how we think, feel, and act toward age and ageism. Secondly, to develop communities and ways that foster the ability of older people to function and be engaged. Third, to deliver person-centered integrated care and primary health services responsive to older persons' needs. And fourth, to provide older people who need it with access to quality long-term care. Now, there are 2 activities that the WHO has established recently that I think might be valuable going forward that I wanted to make sure that all of you are aware of. The first is a global network on long-term care, which includes experts from around the world in various aspects of geriatric medicine and long-term care and palliative care. We had our first meeting about a week ago, which was very productive. And I very much feel that this is going to be an important contribution. The second was that actually today, it being the International Day of Older Persons, today the WHO has established the WHO Aging Data Portal. And this portal brings together data on global indicators relevant to aging and age-related diseases and functional impairments for individuals over age 60. And I believe that this is going to serve as a one-stop shopping opportunity for individuals who are interested in these data. In addition, it's replete with really terrific graphics, great slides for your lectures to students, et cetera. So I encourage you to go to the WHO Aging Data Portal, which, as I say, was just launched earlier today. I believe that IAGG, given our global representation and our interdisciplinary nature of our membership and our leadership, has a terrific opportunity to provide meaningful input to WHO as the efforts associated with the decade of healthy aging are developed. Our capacity to be meaningful partners is very much enhanced by the fact that over the past several years, WHO has included the IAGG and the IAGG leadership in essentially all of its major initiatives. And we're very grateful for that inclusion and that recognition. It's of course ironic in some ways that the launch of the Decade of Healthy Aging coincides with the coronavirus pandemic. And experiences have varied around the world, but it is very clear in general that older persons are especially vulnerable to severe illness if infected with coronavirus, especially if they have a disability or chronic disease. And our experiences have shown that they are especially at risk if they happen to be in a long-term care facility. Our experience shows the lack of preparedness of our population health and public health infrastructure, our lack of preparedness for an acute epidemic, and most importantly, I think, in some ways, the fact that our long-term care system is not designed, it's not built, it's not operated, it's not funded, it's not staffed in a way that is consistent with providing safe care for the patients and providing safe working conditions for the healthcare staff. Long-term care really needs a fundamental redesign. During this session, we're going to hear, as Toni said, from leaders of IAGG's global regions regarding the status and the experience that they are seeing with respect to the inequalities and the disparities faced by older adults. I'm confident that these insights will be very valuable input to WHO as they develop the programs for the decade of healthy longevity, or healthy aging rather. And I thank you again for participating. Thank you, Toni.
Thank you, Jack. Thank you for setting the stage. As we move forward, the challenges are great, but it's nice to have a decade to focus on it. I want to say one of the things I should have said during the introduction is that the panelists know this. This is being recorded, and for those who are attending, I'd like you to know that in case at the end, if you ask a question or make a comment, I'd like you to be aware of the fact that it's going to be recorded. Okay, we turn now to our regional representatives, regional chairs. Now, those of you who know the structure of IAGG, it's an organization of organizations, and the organization is divided into 5 regions. And I have asked the chairs of each of the regions to tell us about what's going on in their region. We begin with Fernando BOTTA, who is the chair of the COMLAT region, which is COMLAT stands for Central and South America.
Or Caribbean?
Fernando, you're muted. Fernando, you're muted. You have to unmute yourself.
No? Yeah.
Oh, there you go.
Do you hear me?
Yes.
Thank you. I apologize first for my bad English. I try to do the better that I can.
The effort, really.
And I read my presentation for the better completion. Regarding the current situation, we have started the decade of healthy aging with the COVID-19 pandemic, which has proved the existence of fragile and vulnerable elderly people. Sorry. The impact of our mental health system practically worldwide poses ethical dilemmas and terrible situations due to lack of preparation. Long establishment didn't have the proper resources with inadequate infrastructure, insufficient and underqualified staff, as well as serious difficulties integrating with health service to bring an appropriate response. Closing doors and let patient die, was an unsigned yet executed decision in many countries. Our Latin American committee, what's wrong? Our Latin American committee issues a communication in May alerting the illnesses caused by SARS-CoV-2 that has spread worldwide is currently causing severe damage to the health system and economies of Latin America and the Caribbean, for which the region was not prepared as they are in the stage of development and in an accelerated process of aging and demographic transition, and affecting in particular the elderly population. Taking into account that the Inter-American Convention on Protecting the Human Rights of All the Person declares in its Articles 5 and 6, the equality and non-discrimination for reason of age, as well as right to life and dignity in old age, the Latin American and Caribbean Committee of the IAGG, COMLAT, facing the current situation with health system collapsing in some regions of Latin America and the Caribbean and state. The care and preservation of human life is an ultimate good which must be ensured for all persons, and that making way towards end of life or palliative care should only happen when the progression of illness or deterioration determine that necessary measures must be taken to ensure comfort with the prepared care. We also state any consideration that take only age into account in the decision-making process discriminate human rights. The proper evaluation of all the person using the instrument of geriatric medicine allow to clearly set the clinical assistance level and the need for resource to keep assistance in accordance with the ethical principles of autonomy, beneficence, non-maleficence, and justice. We such a government should take into consideration the opinion of the different geriatric services in their countries. We should aid in the decision making.
Oh dear. We lost him.
We saw a little bit of internet connectivity issues early on, and hopefully he'll reconnect.
Yes, let's give him a few minutes. But Isabella, if he doesn't connect within the next few minutes, we'll switch to you. We'll move on to you and then come back to him.
Okay.
I think it's interesting he's speaking about COMLAT, but it is, and that region not being prepared, but I don't think any of our regions are prepared. I mean, certainly weren't prepared for this. And we had never yet reached a level of preparation even for normal aging. Let's hope we can address some of these in the decade to come. Okay, Isabella, would you mind taking over? I'll introduce you and then we'll try to get Fernando back. Before you begin, I remind you that you have to unmute yourself. I'm very pleased to introduce Isabella Abderrahmane, who is the chair of the IAGG African Regional Committee. She has a long history of, as do all our regional chairs, of cooperating and participating in IAGG, but in Africa, it's probably the newest region, and so her work has been cut out for her. As one could say. Oh, Mario, you're back. I mean, Fernando, you're back. Okay, well, never mind. Isabella, hold that thought. Fernando's back. Okay.
The internet connection shut down.
Yes, that is the advantage of working virtually, is we can get people from all over the world. The disadvantage is their internet connection isn't always as good as we would like. So,
can I return my position?
yes, please do. And your screen is
let me find the slide. Yeah.
Okay.
Well, here I finish, I think. Sorry. Sorry. Consequently, we encourage the regional government and healthcare system to not discriminate on the ground of base, prioritizing adequate use of resources according to the people's needs, ensuring dignity to all and non-discrimination any circumstance. The preventive measures taken have affected all the persons, violating their rights, subjecting them to isolation more harmful and negative than COVID itself, leading to the compensation of chronic conditions and mental illnesses and exposing the lack of social service that support their needs. The inequalities created by the digital divide have become clear. Truth that all governments have pushed for that older person rarely have access due to lack of training and connectivity and accessibility issues. The WHO defines healthy aging is a continuous process of optimizing opportunity to maintain and improve physical and mental health independencies and quality of life throughout the life course. The enormous inequalities it's related to access to health and social protection in Latin America are notorious, having regions where there are other financial, geographical, and cultural difficulties to the absence of or insufficiency of social protection of all the persons by the state. We have an accelerated process of demographic and epidemiology without having the proper resource or the prior preparation for which we believe new policies must be designed and implemented that include the promotion of prevention and attention to illness in all stages, rehabilitation and palliative care for the elderly. The model of care for older persons must be sought according to the Inter-American letter from San Jose, Costa Rica of 2012, from accessibility, equality in relation to other age, and long-term sustainability, and must include all the persons, their families, and their community. Sorry. The scarcity of human resource trained in geriatric and gerontology should be noted as the lack of integration and enforceability in general health programs. Therefore, we must insist on it, as well as their accreditation to promote the development of gerontological research to know our own reality and meet the detected demand and needs. Self-care program for the elderly must be carried forward to enable them to care for themselves, then and manage their chronic illnesses and delay deterioration. Telemedicine constitutes a tool to be developed for universal access and in remote regions from more developed urban centers. Dependency and deterioration make imperative the creation of global care systems that optimize already existing resources, such as family and community or volunteering with to develop and encourage establishing an integral support network with structures, strategies, and formal funding. Our Latin American Committee issues this June 15 World Elderly Abuse Awareness Day, a declaration for the promotion of the well-treatment of older persons stating, to push for the well-treatment, social inclusion, and non-discrimination based on age, aims in the family and community allows us to give value and to further the participation of older persons in a society for all age. Older persons are our peoples, towns and families keepers, an invaluable treasure for social development and stand as the new active citizen and participant of population agent that bring with great opportunity for development. Then we also we must bring them closer to new technologies and telecommunication closer to them to strengthen the process of social interaction and participation. And we also state we must promote civility, solidarity, social security, and protection, especially involving persons living under extreme poverty, homelessness, those in process of socialization, immigrants, refugees, special population, and groups and support. Caregiving families of other persons with functionally fragile neuroconnective disorders, such as Alzheimer's and the mentally ill. The Inter-American Convention of Protection of the Human Rights of Older Persons was approved by the Organization of American States on the June 15, 2015. It is the first global binding instrument for the human rights of older persons, having been ratified by the majority of the U.S. member states, Uruguay and Costa Rica being the first. It sets a unique and uniform guidelines facing a wide range of legislation, recognize all the persons as a specific group to ensure their rights protection, present gender inequalities in all ages, and incorporate subjects such as violence and abuse and the right of all the persons who receive long-term care service. It conceives all the persons in their integrity and subject of law. It can be a model to follow by other regions of the world and the United Nations themselves. The future. The world face the rise of the population pyramid and to transform the increased life expectation that has led to the increase of years with impairment and dependency into the development of a new active longevity healthy, productive, with new paradigms and thriving economy. Already, today the elderly constitute an important and growing workforce that with their wisdom, expertise, and experience bring so much to new generation. It is necessary to encourage the great ability of the persons to focus health and care service to their needs and prevention. There must be a necessary interaction of all the various areas such as education, assistance, finances, infrastructure, and cities, aligning with people's autonomy and the quality of life, avoiding poverty, isolation, and nutritional deficiencies. Education starting from early childhood regarding aging, whether it's their own or other in society, without non-discrimination and intergenerational integration. Sorry by my English. Let me introduce my member of the COMLAT committee, our committee. You can see Dr. Miguel Acánfora from Argentina, Dr. Marianela Herman from Brazil, Dr. Margarita Morieri from Argentina, myself, Dr. Romero Gac from Chile, Dr. Robinson Cuadro from Colombia, and Dr. Roberto Girón from Peru. Thank you, and I apologize again for my English.
No need to, thank you. No need to apologize. I do recognize the difficulty of giving a talk in a language that's not your native tongue, and you did a very commendable job, and it was very helpful to have the slides so we could read along, and you made very important points that I think is true for all of the regions. I'm not going to make comments, although I'd like to. I'm going to move us along so that we are not too delayed. I turn now to Isabella Abduran, who I introduced earlier when we thought we were going to make a slight change in the order. So Isabella, please unmute yourself. There you go.
Okay. Can you hear
Toni,
me?
this is Jack. I have an echo. I don't know if everybody else does.
Twice, Jack, and you're echoing.
If people could mute.
Jack, could you say whatever it is you said, write it in the chat, because it was not understandable. Okay, Isabella, take it away, but unmute yourself first. There you go.
Okay. Well, thank you very much, Toni. I'm really delighted to be part of this discussion today and to share with you some perspectives from Africa, perspectives on this day, perspectives on the COVID-19 crisis and its implications for the continent and the older people within it, and then perhaps most importantly, perspectives on the collective endeavor that I think we all need to pursue to really advance a successful decade of action on healthy aging. And I should say that these are perspectives that we in the region are trying to bring in to our current initiative and endeavor, working with the African Union to revise the old African Union policy framework and plan of action on aging to really make it fit for purpose for this decade. And maybe what I would like to begin with is a simple but important point, and an obvious point though, which is the importance of never losing sight of the immense variations in social, political, physical, economic, cultural, and demographic contexts that exist within the continent, within Africa, both between and within sub-regions. So when I refer to Africa in my talk, I do so only in relation to statistics that have been estimated for the region as a whole, or to patterns or issues that emerge across countries or sub-regions, or to policy and political processes and debates that are explicitly continental in nature and speak to African countries' own sense of a shared identity and destiny. So with that in mind, let me start with this day, the International Day of the Older Person. My sense is that this day, with its focus on the individual, serves a hugely important function at a time when so much of the global debate and the African debate on the imperative for action on issues of older people and aging is framed with reference to population aging, And certainly for Africa, I think the emphasis on the proportion of older people in the population and the rate of increase within that has been one factor that has contributed to what has been, I think it's fair to say, a relative deprioritization of issues and concerns of older people. With a population share of older people that will remain below 10% until at least mid-century, there has been perhaps a sense that issues of older people are of little overall significance. Instead, as many of you obviously are aware, we all are aware, Africa's paramount focus and concern has been on its huge population of children and youth, with roughly 3 in 5 people under the age of 25. But this is not to say that African countries haven't done anything on aging. To be sure, African states have actively embraced or have themselves forged a spectrum of global and regional accords on and commitments to action on aging. And I guess particularly important in our context today is the WHO Global Strategy on Aging and Health, which all African member states adopted, as well as the African Union Protocol on the to the Charter on Human and People's Rights, which specifically talks about the rights of older persons in Africa. Yet, I think despite these positive steps, and with a number of important and notable exceptions, such as, for example, the establishment and continued expansion of social protection schemes in several countries, a full domestication of these global and regional commitments has hardly ensued. And when I say domestication, I don't just mean the development of national policy frameworks or laws or strategies, but actually the development of plans for programming and, perhaps most importantly, the allocation of budgets to sustain them. At least until recently, I think in some quarters, there's been perhaps an assumption, implicitly or explicitly, that the strengths inherent in Africa's systems and values of family care and support and respect for elders would somehow be sufficient to make up for these gaps in active programming and active investments in aging. Well, the COVID pandemic has upended all of this. We are now faced with a stark realization that the structures, the arrangements we have in place to ensure the care of and support of older people and their participation are not in fact fit for purpose. The crisis has thrown into sharp relief the systemic gaps, underinvestments, and precariousness in Africa's old age care and support systems and environments. And while we don't as yet have robust evidence, on the impacts of COVID on older people in the continent, all indications are that these gaps have made possible grave impacts of COVID on older people, on their right to life, to health, to freedom from neglect and abuse. Where systems in some countries have been a little bit more developed and responsive, for example, enabling a temporary increase in social pensions in Kenya, in Cameroon, or in South Africa, the impacts of the crisis have perhaps been lessened. I should also say that while we focus on the direct impacts of COVID on older people, it's important to also consider its likely impact on entrenching the existing inequalities within the older population along gender, socioeconomic, geographic and other signifiers of social status, but also between older people and younger people, age-based inequalities. Now, I would say that, and there is a feeling in our region that the deficits in our old age related systems, structures and environment that have been exposed so starkly by the crisis offer an opportunity for us, an opportunity to rethink, to reimagine the kinds of homegrown systems, if you like, of care, support and participation that Africa needs and can pursue, building on its own strengths. And we also think that besides the opportunity to rethink and reimagine, there is an opportunity at this juncture to really make a decisive push to advance the full domestication and implementation of the commitments to action on aging and health that governments have already made. So I would say that our collective endeavor at this juncture needs to be certainly within the IAGG Africa region, needs to be to contribute towards this push towards an implementation and a realization of the commitments that African governments have made. So what would that involve? Well, my sense is that it needs to involve, first and foremost, a concerted research and policy engagement endeavor that explicitly seeks to address the barriers that have so far limited the will to invest in issues of aging and health and older people. And while we have yet to properly investigate these barriers across various national contexts, the indications we have thus far point strongly to three key barriers. The first, most importantly perhaps, have been views among key decision makers and policy makers and other political constituencies which see investments in older people as essentially irrelevant, or at least only marginally relevant to overriding economic growth and development priorities, including agendas around youth-focused development. And I should say that these agendas, these overriding development priorities, have gained so much more urgency now in the context, often in the aftermath of COVID, as the crisis threatens to reverse the development gains of Africa of the last 2 decades and to push a further 27 million people into extreme poverty. A second barrier, even where there has been an interest in action on aging, has been simply an uncertainty among policymakers about what concrete approaches or investments to pursue, in particular approaches and investments that build on existing structures, that build on the strength inherent in them. And then a third barrier has been the absence, and I think this is also very important, has been the absence of a substantive advocacy coalition or a set of advocacy coalitions to champion the cause. Now, there is a spectrum, obviously a large spectrum of civil society movements and groups that work on agendas that have a direct stake in issues of aging broadly and issues of healthy aging specifically. Groups and constituencies working on issues of gender, women's empowerment, youth, jobs, these are all related and have a stake in healthy aging. But yet they have not so far coalesced around this common interest. So what would a concerted research and policy endeavor need to do to address these barriers? Well, I would say there are 4 things in particular that we would need to consider and need to pursue. The first 2 have to do with the substantive areas for inquiry that we might want to prioritize over the next years. First is to clarify the case. And I should emphasize, through research of the highest quality, both empirical and conceptual, clarify the case for where and why and how investments in healthy aging are in fact relevant to advancing overriding agendas for development, including agendas focusing on harnessing Africa's young population, in particular to nurture a demographic dividend. And the second area of inquiry for us needs to be to clarify directions for action and for investments by showing what models can be pursued where and how they can build on existing values and strengths. The second 2 things that I think we need to pursue and embrace as we go forward have to do with the kinds of approaches that we use in the research and in the evidence that we generate. The first approach has become almost a cliche, but it's critically important, which is the importance of co-creation. We need to foster evidence generation that is shaped jointly with and seeks to engage key policy, advocacy actors, and stakeholder communities. And we need to ensure that this evidence generation makes room for those also who are outside of existing hierarchies to contribute vision, ideas, and thinking. The second approach that we need urgently to embrace is one of fostering research and evidence generation that is Africa-led and Africa-owned. At the moment, much, if not most, of the research on issues of aging in the continent is done collaboratively between African institutions and those in the global north. But I would say that the decolonial turn in which we find ourselves at the moment and the imperative of social justice at its heart as well as what we see as increasingly explicit requirements by the decision makers, policy makers, who we want to use our evidence, demands new approaches to global North and Africa research partnerships, approaches that explicitly recognize and overcome the historically rooted power and epistemic imbalances in knowledge production, and that ensure, as I said at the beginning, that research is really truly Africa-led and owned. And such approaches, I think, need to address asymmetries on several levels. One is in the financial control and management of projects. Another is in the determination of agendas, priorities, and locations for inquiry. Another is in the epistemological and methodological approaches that we embrace. And then a final one, which perhaps is most important, is in the way we engage with existing Anglo-European centric theories and constructs. And if you think about it, these are all we currently have in our gerontological toolbox. So maybe I will end with a thought about the broader relevance. I mean, if we embrace these new approaches to research on aging in Africa, and if we are able through them to help advance real, true action and investment in healthy aging in the continent, we would also at the same time strengthen and serve to advance the global scientific endeavor on aging as a whole. So these are some of the thoughts that we are currently developing within the Africa region and that we are seeking to bring into the new framework that's going to guide policy making and action on aging in the continent, the new AU plan. And I look forward very much to your reactions to discussing the points made, and I would like to thank you very much for the opportunity.
Thank you, Isabella. You remind us of very sound policy principles, scientific principles, and just plain practical principles. And I think they would serve us well moving forward. We turn next to Ken Madden, who's chair of NARC, the North American Regional Committee. And take it away, Ken.
Hi, thank you. Thank you everybody for inviting me. I'd like to discuss how the pandemic has affected the IAGG, basically moving forward over the next decade. And it was kind of depressing when I did this talk, because basically I could have written this talk in 2019. It'd be the exact same items. It's like that famous Mark Twain quote, history doesn't repeat itself, but it often rhymes. Basically this COVID-19 pandemic just amplified structural inequalities and issues that were there before. Now this amplification posed a lot of challenges over the next decade, but it also is an opportunity to address things we've been trying to address for a long time. Now obviously, I could have a list of 15 things. I think the three that occurred to me the most, I'd just like to spend a couple minutes on each one, is social isolation in older adults, the issues around long-term care and residential care, and then most importantly, ageism and the lack of intergenerational solidarity. Now, Americans and Canadians are living more and more alone. This is Canadian data, but basically more and more of the Canadian population lives alone over each year. And this is, and this is having an impact, this is American data, but approximately 14 to 15% of all Americans say that being lonely is a major or minor problem. And this has a great deal of health impacts, specifically, if you're socially isolated, living alone, feel lonely, your chance of mortality is the same as if you start smoking. So the health impacts are huge. And we've basically done a massive ecological experiment on our older adults. People in residential care aren't getting visitors, people are scared to leave their houses. Whatever issues with loneliness and social isolation happened in 2019 have essentially been doubled. But there's also potential. From a technological point of view, this isn't the same world as it was 10 years ago. This is a little out of date data, but in 2013, approximately 60% of older adults were online. And I suspect over the last few months, a large number of older adults have gone, even more of them have gone online. So there's opportunities to try to intervene. So I tried to think, what are things we could do at the IAGG level to help with this issue? Obviously, we've done this massive, almost ecological study of social isolation. I'm wondering if the IAGG could help increase some of the knowledge translation focus. Every time I go to the GSA or the IAGG, there's numerous panels talking about, social isolation and the income and the bad impact of these issues. But maybe we could have some knowledge translation studies, trainee grants, intervention trials. There's a lot of technological intervention around aging out there in the engineering faculties. Maybe we could actually do some RCTs of some of these interventions. And then in some ways, even though our collaboration is more difficult because we can't get together, given that everything's virtual, maybe this might be easier. Certainly our cities need to be better designed to discourage social isolation. Certainly in North America, we have vast tracts of suburbs and exurbs with no community space. In some ways, it's easier to invite policy leaders into these debates because everything is virtual. With respect to residential care, Canada, out of the G8, has more of its older adults in residential care than any other G8 country, and the US isn't far behind. So we use residential care a lot, but it's quite a neglected area of the healthcare system. And all the problems that were present in long-term care were greatly amplified by the coronavirus. This is just a headline from Time magazine. It's getting worse. Nursing home workers confront risks of facilities devastated by coronavirus. And in Canada, it got to the point in Ontario and Quebec that we actually had to bring in the military to help look after our older adults, which is quite horrifying for a country with our resources. Now, the only benefit of this happening was the military is very good at documenting things. So the military documented all the conditions in these facilities. And everything they documented, shockingly, had nothing to do with the pandemic. It wasn't a lack of PPE. It wasn't a lack of oxygen. It was all, things about people not being changed, people not being fed, bed bugs, horrible conditions. These are all things that the military would have found in 2019, quite horrifyingly. And part of the issue is one area of social injustice is causing another area of social injustice, that we aren't giving people a living wage who work in long-term care. So if you don't get a living wage and you work in numerous sites, if you work in numerous sites, that spreads the pandemic. This is US data, but big marginalized and individuals tend to be used in these facilities, and they don't have any power, they were not paid enough, they don't get a living wage. And the idea that a group of people we're not paying a living wage is going to stay and look after older adults in a massive health emergency isn't a good policy. Most of them did. They heroically stood by their patients, but at a policy level, that obviously was never going to work. So what we're going to do in the future is I always consider gerontology quite a broad, multidisciplinary field, but maybe we're not broad enough. I'm always proud of the fact when I go to an IAGG meeting or the GSA, I meet a new colleague in a field I'd never ever interacted with before. But this demonstrated that a structural inequity in an area completely outside of my area of research can directly impact my patient population. For example, in 2019, if you asked me about residential care workers, I would say they have a lack of a living wage, and that was a social injustice. But it never occurred to me that that would lead to pandemic spread and kill thousands and thousands of my patients. So the question is, how can we maybe increase our breadth of collaboration when all the traditional avenues are blocked? We're not meeting for meetings anymore. In some ways, we have an opportunity because we're now meeting virtually. Maybe we could have special interest groups that meet regularly every 4 years. Certainly at the Canadian level, during the pandemic, we immediately started a long-term special interest group with the Canadian Geriatric Society. This spread. This probably would have taken us 5 years prior to the pandemic, but given that everything was virtual, it spread all across Canada. We were able to share clinical tips. We were able to get policymakers involved at the federal level. It was much easier because people didn't have to fly anywhere. So maybe collaboration might be easier, and it's definitely going to be cheaper. And the last issue I think that was raised by the pandemic is basically ageism and a lack of intergenerational solidarity. And I have to confess, in 2019, I was somewhat naive about this issue. I knew there was ageism, but I thought with the baby boomers being over 65, I thought that's just the sheer number of population might help this issue, just because such a large group isn't going to put up with it. But that was completely inaccurate. Here's just an example. This is the Globe and Mail saying that, they report on COVID deaths and they say, oh, there's 4 more deaths, but they're all elderly, just completely dismissive. And just this dismissive way of marginalizing this population is quite shocking how quickly it went. And then you also see it in the US. Most intolerance tends to have a contradiction to it. So older adults were simultaneously helpless victims without any autonomy, but they're also responsible for their own issues because they weren't taking coronavirus seriously. So you're a helpless victim, but you're also spreading the virus because you don't wear a mask. So it's fairly disgusting how quickly we turned on our parents and our grandparents. This is completely anecdotal, One of my patients in clinic the other day told me that growing up as a gay man in the 80s, he said the rhetoric that was put against him during the HIV epidemic, he said it was almost identical to the rhetoric he's getting now during the coronavirus epidemic, just for different reasons. So is there anything we can do about this? There's a vast volume of work, obviously, about ageism and effects, but how can we change it? Maybe we could fund some limited KT collaboration grants. I kind of think we might be able to take a page out of diabetes conferences. Every time I go to diabetes conferences, there's always a keynote from a marketing person. Because the idea is they don't want to yet do another study that exercise is good for you, that you shouldn't eat sugar. The idea is they want to change behavior. So maybe we need to broaden out our collaborations, public health educators, marketing and researchers. Admittedly, this isn't my field, but we have to admit the fact that no one reads academic papers, no one's going to read policy papers, maybe sales experts, and people more in that area of field can help us in this area. So those are just some thoughts I had of kind of, there's many, many issues amplified by the pandemic, but I think those are the top 3 that crossed my mind. And I think over the next decade, we have an opportunity to help rectify some of these issues just because they've been raised so prominently.
Absolutely. Thank you very much, Ken. I am quite sure we'll come back to these points you've made, but it may be one of those benefits of the pandemic that I was talking about, where people have really begun to come to recognize the importance of social connections, of isolation, of loneliness. And you didn't mention, but the other side of that is the increased amount of domestic violence resulting from people spending all that time alone together. We'll come back to that. Our next speaker is Mario Barbagallo. Is that how you say it, Mario?
Yes, I'm here.
Aha. Mario was challenged because he had an unexpected travel that he had to do just as we were getting started, but he's happily here. And we see him.
Yeah, I'm very happy to be here. And first of all, I want to thank you, Toni, to have organized this meeting and to have a chance of discussing with all the chairs of the different region. And it was great to listen the talk of our president, Jack Rowe. Hi, Jack. And I'm particularly happy to discuss with you the situation in Europe, because actually Europe and Italy in particular was hit very heavily by the COVID-19, and actually was just after China. As you remember, Italy was the first country, and then all Europe, Italy, Spain, France, to be actually hit by the COVID-19. And another peculiarity of Europe is actually we are actually now seeing the second wave, because what we most of us thought that after the first wave in May, they start actually in February, March. When in June, it looks that everything was almost going down. There was very few cases, but now it's increasing in all the European countries, in Italy and in France and Spain in particular. And this is a problem for all people of this country, but in particular for the elderly people, because as you know, what happened at the beginning. That of the first wave was a drama for the elderly, because no one knew the virus as much as we know now, and actually the advice of most of the government was in Italy, in France, in UK, was to keep the elderly people in their residence, in the long-term residence, nursing home, rehabilitation center, and facility for all the people. And this was actually a drama, because what happened was that almost 50% of the people that died in the first few months was actually elderly people and elderly people living in this nursing home and the rehabilitation center, which actually a drama, because actually instead of protecting these people, there was a concentration of elderly people in the nursing home that so the people getting from outside that were spreading the virus in these residencies. And what's happening now, it's a difference, because the second way is completely different from the first one. What happened in the first way was that the mean age of the people with positive with the virus was 60 years, and deaf people that died, the mean age was almost 80. So most of elderly people, the mean age was 80. If people were tested and were positive, the mean age again was around 60 years. What's happening now? Now we are testing more younger people. So we have a difference, because the mean age in September in Italy, the mean age of people that were positive the mean age was 34. Completely different. But if we go back to people who die, they are still the elderly people. So what changed was the people that are positive, that are the young people, and what's even more dangerous, that the young people are positive and very often are asymptomatic. So they can spread the virus to the old people. And the old people that, in particular, if they have comorbidity, in particular if they have frailty and disease, they die. So that they have the more severe disease, and they die from the disease. So what's happening now is that we have a very young age for the positivity, but still the people that get in the hospital and people that die, most of them are very old. And in particular, if I go back with the people that they die, they have a very high comorbidity, in particular with people, in particular with diabetes, cardiovascular disease, cancer, of course, dementia. And I have the data of June. 28% had cardiac problem, 15 cardiac failure, about 67% were hypertension, 30% were diabetes. So people with older age, people with disease were the people that more often die. While now people, the younger, they are still get the positivity, but they look to be much more protected. Why people? Why this virus is why these people strike older people? Why these people are more often get the serious disease and more often they die? For several reasons. First of all, because as I said before, they more often have disease, they more often are frail, and also because there's some connection with the cytokine increase with age and increase with frailty. So probably there's and you know how much this virus is cause a cytokine increase. So this is a drama for the elderly people, and I just want to read some of the report from in Europe from what's happened in the nursing home, because this is actually a drama in the drama. Because actually, because there was actually a silent murdering of people in all the country. Even also in the United States, there was people in residency were hit, but in Europe this was much more important. And actually what the elderly people paid to the virus is the most important balance for all Europe. In all Europe, as I said, all the journals. I mean, in the COVID-19 in France was only 40% of the mortality in France up to in March, April, May, and June was in nursing home. In Italy also, and so people were also isolated. Completely, because when the virus, the positivity spread into the nursing home and to the hospital, was not possible to get in contact with the relatives, with the son. And actually, I have to say something more, because my hospital is a COVID-19 hospital, so we are living the drama in the hospital of these people even now. And these people are completely alone. They stay in the hospital because they cannot see of course their relatives. They cannot. They most of them, they will die into the hospital and without even the presence of a son, of a wife, or a relative. And this is a big drama for the social drama. So it's we as doctor, we have to stay together with what we can do is just to get in contact with the remote and then get the phone, but it's not the same. They need caresses, they need the contact, and when the patient say, doctor, tell me, are we going to die? And what we can say, we say no, but sometimes, of course, this is we actually, this is not true. So this is what we are experiencing in now is all over the world, but the peculiarities Europe that we actually we had it the first of all, and they actually taught the other region how to try to deal as much as we can with the virus. And actually, I do believe we have to deal with that until we have the vaccine, and I hope it will be soon. That's it for now. I mean, I am open to discussion and to listen to you. Thanks, Toni.
Thank you. Many of those points resonate around the world, and hopefully we'll have time to come back and speak to them in a little bit more detail. So we go from Italy, Europe, to the others, literally the other side of the world. Julie Biles, who is speaking on behalf of the Asia Oceania area of region of IAGG. And Julie, everyone should know, it's the other side of the world, and it's the middle of the night. So I really, really appreciate your willingness to be with us.
Well, thank you, Toni. It's actually almost early morning, so so I either had a late start or a night or early morning. Yes. So thank you. Hopefully everyone can see my slides now.
Yep.
Yeah, okay. And
you might want to put it on presentation mode.
That's right, yeah. Okay, there we go. Okay, so first of all, I'd like to start by acknowledging that I'm giving this presentation as the representative of the IAGG Asia Oceania region, with the support of my colleagues from across the region, including Professor Derek Chan and Professor Cheng-Chi Lin from Taiwan, who will be the incoming leaders of the region when we next transition, and also on behalf of President Assantai and Sirifan Sisat, who are the current leaders of the region. So I thank them for their support in nominating me to represent the region, and also like to acknowledge Dr. Ashish Goel from India, who also provided quite a lot of input into this presentation. So thank you to those people. So our region is a very diverse region. It's large and diverse, and it's also got a very large number of people over the age of 60. And given that we include India and China, it's, I think, a very large share of the global population aged over 60. Many of the countries in the region have very rapid pace of population aging. So, and that provides a particular challenge in many of those areas. And many of those areas, their population's aging at the same time as their economies are developing. So those provide other challenges as well. We see great variation in life expectancy at birth from probably the world leaders in Japan, and then contrasting that to Laos, PNG, and other parts of the region. And then within countries, of course, we also see big variations in life expectancy for different subgroups of the population. So for Australia has quite a high life expectancy overall, but if we look at our Aboriginal and Torres Strait Islander people, they have a lower life expectancy. And so this gap in life expectancy at birth, life expectancy, healthy life expectancy, they are also important challenges for us to note and deal with. Most of the countries in the region are experiencing increasing disability burden from non-communicable diseases, and that's true globally, but many countries are also experiencing this at the same time as having a high burden of disease from both infectious diseases, communicable diseases, and injury as well. But I guess now everyone's got a high burden from communicable diseases. If we look at COVID, again, we've got a very big difference in the impact that COVID has had on countries in the region. So India has a very large and rapidly increasing rate of cases of COVID and deaths from COVID. China, of course, was the epicenter, but did manage to have some very effective controls. Australia has had waves, and they've been major issues for us, but not look pale in comparison to some other parts of the world. But some countries like Vietnam have had very low transmission of COVID, partly because they were primed already by previous pandemics previous epidemics such as SARS. And then if we look at Taiwan, incredible exemplary response to COVID, and they have had 7 deaths because their response was fast and firm and incredibly effective. So if we're looking at the decade of healthy aging, I think what we're all striving for is a world in which all people can live longer and healthier lives. And if we focus on a few particular things in looking at that, so age-friendly communities, person-centered integrated care, community-based social care and support, but underpinning that with making sure that older people's voices are heard, they're engaged, and they have leadership and capacity in affecting the world that they're living in. Connecting stakeholders and underpinning all of that with research and innovation. And then as we move forward over the decade, understanding and measuring our successes, or where things aren't successful, learning from those lessons. Oops. Okay. So if we look at what the priorities for healthy aging might be in the Asia-Oceania region, they would include accessible, affordable, high quality, long-term, comprehensive, dedicated health and social services to improve quality of life of older people, income security, adequate nutrition, education and empowerment for older people, for older people, perhaps even by older people. Strengthening capacities for families to take care of older persons, and I would include in that compassionate communities as well. Courses on gerontology and geriatric care to make sure that we have an adequately trained and resourced workforce. Developing age-friendly cities, universities, support groups and communities. So it's been referred to as a new architecture for ageing, our built and social environment, the architecture of that, and meaningful data on ageing. So if we look at how these objectives might be being strived for in different countries, if we look first to India, which, as I mentioned, has a very, very large older population, a very large share of the global population over 60. Their strategies to promote healthy ageing include integrated program for older persons to improve quality of life through shelter, food, medical care and entertainment opportunities. A program that provides aids and assistive living devices for economically deprived people, particularly those with low vision, hearing impairment, loss of teeth and locomotor disabilities, and a program for geriatric care. There are also programs for older adults, including the National Program for the Healthcare of the Elderly. There's a Prime Minister's Insurance Scheme, a Post-Retirement Security Scheme, health insurance for senior citizens, an insurance of the pension, a scheme for providing aids, and non-government organisations which provide quite a strong basis of support for older people across the country. We look at a different country in our region, look at Nepal, and this information was provided by the Nepalese Society of Gerontology and Geriatrics. Their priorities for healthy ageing resonate again with those of the region, with access to healthcare, safety for older people and financial independence. So they provide supplement and pension and supplement for older people, free treatment in government hospitals, some medications are free. They have a health volunteer program, but there's a need for better education of those volunteers and support for that volunteer workforce. They have some plans for geriatric wards in all regional hospitals throughout the country, but they lack geriatricians and geriatric nurses. And they also have plans to extend that to district hospitals. The government's preparing training manuals for geriatric nurse training and care training. And every local government has a committee to address safety issues for women, children, and senior citizens. Senior citizens have meeting centres where they can address isolation and loneliness. And the national budget provides grants to local government to implement targeted programs such as the distribution of food and door-to-door health services. And the government plans to implement an intergenerational knowledge transfer program. So there's a lot going on in that country. We look at Thailand. They have general policy objectives to encourage older people's clubs, schools, quality of life development and career promotion centres, to support and provide older people's enabling and friendly housing and environment, all public service systems to be accessible and usable by older people, to promote employment and promote occupational training for older people, to organise health promotion activities for older people and their families, to establish older people's clinics in public hospitals and rehabilitation services, and to look at the health and social services, including community-based long-term care, emphasising a home care model. Now, in Taiwan, they're actually promoting age-friendly healthcare. They've been doing this since 2010. The goals here are to ensure equal access and high-quality coordinated healthcare for older people, to determine effective prevention and treatment practice, and to work with the community to promote best practice to enable healthy ageing. And the organisational implementation flowchart, I think, provides some really helpful steps in how to go about doing this. So starting with very high level support, creating teams, assessing at different levels of the organisation, patients, staff and the community, identifying the weaknesses and resources, planning, assigning roles to people, getting things happening, implementing, and then of course, really importantly, monitoring and improving, and then sharing and recognising what's happened. So in doing that, working through that flowchart, they've been able to increase the number of hospitals in Taiwan which would be considered to be age-friendly. So they now have 469 health services recognised as age-friendly health services through this process. Also in Taiwan, they've been working towards an age-friendly country, age-friendly all of Taiwan. So the Health Promotion Administration has been actively shaping Taiwan as an age-friendly society since 2010. So in 2018, almost all of the country is purple, which means that it's a very age-friendly environment. So that's something that we can all aspire to having our whole country glowing purple with age friendliness. There's some other specific examples of really great programs that have been very successful in helping older people. So I draw on one example from Singapore, the Community for Successful Aging at Whampoa, where they've had a community-wide approach to forge an integrated system of comprehensive services which promote the health and well-being for people across the life course. So it's intergenerational, but with a focus on aging and enabling aging in place. And what they've developed there is an understanding of the needs and the aspirations of the older people in the community and what resources are available to help with their healthcare, but also their personal growth, because that's just as important. They provide integrated care within the community. They provide opportunities for community participation. They have a learnings room where people can come together, learn together, and all of that is integrated with a platform of research. And the philosophy there is that a person needs to be recognised as much for their continuing potential as for their past contributions, that they thrive on social connectedness, and that isolation, loneliness and boredom thwart best attempts of medical care. So you can't have good care if you don't have people who are connected and aren't isolated and lonely and bored. Another example throughout the Asia region, which I think is a great example of what older people can do for themselves, is the self-help clubs promoted through HelpAge International particularly. So it's a village-based model, it's community-led, and because it's from the ground up, it's sustainable, it's comprehensive, it's affordable, it promotes healthy aging and active aging, where people are cared for and promoted, but through the untapped abilities and potential of other older people in the community. Those older people become agents of social development, not passive beneficiaries. So that's a great model, I think, that many other communities can follow. Now, in response to COVID, people in the region got together very early in the pandemic and put out a paper on how we can prevent COVID-19 in older adults. So it came from the IAGG, Asia Oceania region. And I just highlight their little mnemonic here about the COVID IAGGAO. So the catnap, the being optimistic, having vigor, intaking of adequate nutrition, distancing, increasing social support and contact while you're distancing, medicines, sunlight, going to the emergency room if you're sick, washing your hands, and ordering your foods online. So that was, I think, great advice that stands up early in the pandemic, but stands up. And many of the countries have also put out information flyers, posters, and colourful advice for older persons in their communities. So a couple of examples of those things here. So I'm just going to conclude with Australia, seeing as that's where I am at 4 a.m. or whatever time it is now. In Australia, we've been taking some pretty strong action on ageism through a program called Every Age Counts. And here are a number of us, including Sir Michael Marmot, signing up to the Every Age Counts campaign. I think that's a very important underpinning of anything that we're going to do towards healthy aging, is recognising that older people are citizens and have rights and should be participating in the development of their own destinies. On top of that, we do have a very long established long-term care program. It's undergone quite a lot of reform, but with currently with a focus on access to aged care and packages for older people to support them in the community. But we also have a very robust and vigorous inquiry into quality and safety in aged care, which predated the COVID pandemic by a couple of years, but which is again highlighting all of the limitations and failures in aged care, despite our very well established experience with aged care. And I think everybody's recognising these things in other parts of the world as well. In moving forward, we have a focus on reablement. So not just seeing care as compensating for people, what people can't do, but seeing care as promoting what people can do and helping them to maintain those abilities. And I like to think of there being a wide window of opportunity to provide such reablement for older people, and that long-term care can be the long tail of prevention. So you're always preventing the next disability, and you're also always preventing poor health outcomes right to the end. We do have an Age Discrimination Act, but as yet no commitment to the Convention on Rights of Older Persons, but we have a very active civil society group that's campaigning for that. And we also have a well-established aged care diversity framework, which takes into account Aboriginal and Torres Strait Islander people from different cultural and linguistic backgrounds, and the LGBTI community. So I'm just going to finish there, and thank you. Toni, I think you're muted.
You're right. Here we go. Thank you very much. And that was really very nice because you had so many positive things to report on in so many different places. People, I mean, it's all the same region, but it's very clear as you told us about different activities that they represent very different cultures. So that's leaves us on a plus note, not denying that there's reality to all the problems we face, but there's also kinds of problems that we can tackle. So thank you all for pretty much sticking to time. We do have some time now for questions, comments, and I will turn it over. I look through here. I'm getting there is one question in the question and answer, but generally if you have a question or comment, please put it in the chat. But I will ask this one question, which is to Mario. Could you provide, how would you provide better contact of dying patients with their families and still protect those who are healthy?
That's a big problem because so what we actually doing is contact with iPad, with telephone, video imaging, and but there is no other way. I mean, because there is no possibility from people to get in, even to bring things inside or outside, because all the COVID environment, it's I mean infected, so it's and the virus is so easy to spread, so there is not any possibility to people to contact. And this is, I mean, this is really for now we are in the middle of it, but I believe in the next years there will be for geriatrician, for gerontologists, there's a lot of talk of this drama of these people dying without the possibility of getting together with their relatives. This is really the most terrible drama in the drama of the COVID-19. So that's what I mean. Because yes, they can see the relatives outside can see with the video, with the video camera, with the iPad, but it's not the same.
It's not the same. Of all the difficulties, that just seems like really among the worst. But it is interesting and creative how people are managing. Though all of the technological connections are not the same as
at least now we have this. A few years ago, probably this was not even possible. This.
Yes. Okay, I'm looking at, there was another question. Let me see if I can find it. I have been asked to provide your emails, the emails of the panelists. If anybody has any objections, please let me know. Otherwise, I will share. Mario, you're in two places now. Let me ask our panelists if you would like to make any comments now that you've heard everybody else. Would you like to make a comment or say any, offer some comments about other people's presentations? I will say, many of you have touched on the issue of social connectedness, whether it's confronting end-of-life issues or trying to be responsive to the whole notion of being locked down. It's interesting, even the way countries talk about it, lockdown, sheltering in place, quarantining, all of these different kinds of labeling probably says something about the way the country has contextualized it. But what's really impressive to me is the degree to which people who have never really recognized the importance of social connections for health are beginning to recognize it. I mean, I think that may offer an opportunity, because the people who would say, oh, that kind of stuff isn't important, now cannot deny it. And I loved it. In the US, we had periods where the governor of New York, for example, was having daily press conferences when the situation was very, very bad in New York. And he was telling everybody how social connections were important. If you're sheltering alone, be sure you call somebody. If you know somebody who's sheltering alone, be sure they call somebody. Though Mario, you should know, he's Italian, so what do you expect? But still, this is not the sort of thing governors would say under normal circumstances. So we have perhaps an opportunity. Linking to what Ken said, was it Ken? Was it you? Yeah, it was you who brought the whole issue of intergenerational relations and conflict, right?
Yes, yeah, that was.
So years ago, actually at GSA, one year, the theme was essentially intergenerational conflict. And I'd hoped that it had died, but I think you're right, it hasn't. And now the young people are blaming those old people who are boomers for not taking care of the problems they're confronting. So why didn't we do anything about climate change? Why have we let things get so out of hand? So, now with resources being limited, I think it's going to be even worse. So I think we really have to confront this whole notion of intergenerational conflict. But I think that we as gerontologists should be mindful of this and incorporate ways to improve intergenerational relations, solidarity, and interactions. As some of you have mentioned, there are many things that older people can contribute. And even now, as we have older people contributing to the care of their grandchildren, as the parents of those children are sheltering at home and trying to work and take care of the kids and educate them all at the same time, is really a case in point of the positivity. Nora Keating sends a chat that she'd like to ask the panelists what they see as the main knowledge gaps that we need to address as researchers to provide the evidence for action on healthy aging. And I'll put that out there. And another question from Arvind Mathura, with home-based long-term care being protective, should we promote and strengthen it?
Well, I think from my point of view, one of the knowledge gaps is in terms of social isolation, what works and what doesn't. We have all these new technologies and and certainly it's a North American bias. I think we can just throw technology at a problem and it'll fix it. But I think anyone who's been in a Zoom meeting realizes it's not the same as normal social interactions. So we need more studies to figure out what works and what doesn't. Because this addresses an issue, as I say, that was a problem even before the pandemic. Social isolation was a big issue. If we could figure out ways to get around it using these new technologies and figure out what works and what doesn't, I think that'd be a huge benefit.
I mean, even if you don't, we all recognize that a Zoom meeting is not, a Zoom meeting, social meeting is not the same as in person, but it's a lot better than no connection at all. So, all right, before I go on to another question, anybody else want to comment on the things I've just repeated, the questions I've just repeated?
Toni, I just want to comment of the interregional, intergenerational point of because I want just to add about the drama of COVID, because the elderly people, not just I discuss about mostly people in nursing home. I now want to just to add that even people that are healthy and stay in their homes, the advice we are giving is to stay away from the grandchildren, because what's happening now that the schools are opening and there is a spread of the virus is that the young people, the children, are asymptomatic, and they are actually infecting the older people that they get the disease and they die. So this is actually another drama, that even all the people that are not infected, and they should stay isolated as much as they can from the young people, because the young people that they may have the virus and not are asymptomatic. Yeah. So this is a big problem, because the young people, they don't understand. Most of young people, at least in Europe, you saw in the television what's happening. They do not understand. There are someone that even negate the virus. They mingle. They go to this. So that's when they get together with the older people, they got. And they may die. So this they isolated. This is actually intergenerational split that will also cause more problem in the future, I do believe. I don't know if someone want to comment on that. Is this in the other region is the same? But we are experiencing that all the people, they stay home and they do not get out, and they don't mix with even the relatives, the young people.
Yeah, you know, your comment. These are issues I have been aware of, but your comment makes me realize something that I hadn't been as mindful of before. In fact, so my trend of thought was that now in the U.S. we're having new hotspots, meat packing industries, factories where people are packed in, but also college towns where kids are coming back to college and they're all becoming infected, and then there's a new hotspot and it's spreading around. But what I hadn't thought about before is the way in which in the early days the potential for spreading was almost downplayed because it was affecting older people. It was almost as only older people, so don't worry about it. Whereas, I mean, it was affecting older people who were vulnerable. And of course, it affected, you know, the way they would talk about it is older people and people with underlying conditions. Okay, so you're getting the weak and vulnerable, and now it's starting to go to the rest of the not so weak and not so vulnerable. And we're having more and more reports of, I read one this morning of a 19-year-old who had no underlying conditions and got COVID and died within a very short time. But we did a disservice, none of us, of course, we did a disservice to the society by reporting this as only an issue for older people, and therefore creating a sense of false security towards others. Let me go to some other questions that are coming in fast and furious. I'm not sure if I said this out loud because I'm reading them while listening. So Nora Keating asked about main knowledge gaps. Did I already ask that question? Repeat that question. So she asked about main knowledge gaps that we need to address as researchers to provide evidence for action as we move into the decade of healthy aging.
I said one thing, but I'm sure there's others.
Maybe I can just reflect on that a little, Toni.
We can hear you, but you're not very loud.
Is this better?
Yep.
It's better. Yeah. So, well, I think my answer to that question also centers on the importance of better understanding the intergenerational links that exist between old and young in the African context. So what we need to do, as I mentioned, I think the most important task that we have in terms of evidence generation and knowledge gaps is to show where and how issues of aging and health, and I suppose more specifically the capacities of older people, are actually relevant to main development agendas, in particular youth-focused, child and youth-focused development agendas. And I think there are a lot of points of relevance which hinge ultimately on the intergenerational links and connections, either active or passive, explicit or implicit, that exist between older people and younger generations within families, communities, and societies. But we don't really understand them, and we don't really understand what the implications are, both for the older and for the younger generations. And I think that's sort of the crux of what we need to explore going forward. And that's that. If I were to choose one key knowledge gap, it would be that, to see where and how are the lives of old and young linked in our societies.
And we know they are
for development.
We know they are linked, but we do downplay it. And I think we know in some ways, but there are many other ways that we don't even recognize.
Exactly. And I said, yeah, where and how exactly are they linked? I mean, that they are linked is clear, but you know, we need to pinpoint that and what the implications are.
And Frances Zanodin, sorry, Frances, if I say this wrong. She makes a point that I think we should recognize as well, and that is that while we are downplaying or chastising older people for what they're not doing, we really do need to recognize that they did a lot. They did, and as she says, they fought for the right to vote, for women's rights, for the civil rights movement, etc. And the first time I was on the receiving end of this chastising from a younger person, I was shocked, because like I come from the generation of the 60s. I thought we did a whole lot. And I mean, that was then and this is now, you know how it is. And there's a lot more to do. So maybe we young people, when we were young, we thought we were done. And we all know now you're never done. Some of the problems are the same, and some of them evolve and some of them are completely new. So, all right. Here's a question from Laura Machado in Brazil. She's a member of our UN team. She asks, which action members societies, well, first I should say, I would skip the nice part. She said, congratulations to all of you for your presentations. And then she says, which actions should member societies and IAGG, what can they do to contribute more closely for the decade of healthy aging and for the promotion of a convention on the rights of older persons? Should IAGG work again in a research agenda on aging globally, for example, where we can collect evidence on the implementation of policies on aging, and especially for the protection of the rights of older persons for the next decade? Would this help a lot? Or do you have, would this help a lot the work of IAGG at the UN level in in contributing to how we confront COVID in the world.
Toni, this is Jack. I think Nora Keating might be asked, if she's still on, to respond to that. She's been thinking and taking the lead in efforts to think about how IAGG and other international organizations respond to the current and probably future conditions.
You know, I'm just realizing that people are having to write the questions because they need permission to talk. But I think I just gave Nora permission to talk.
I think you did, Toni. Can you hear me?
Yes, very well, thank you.
Thanks very much, Jack. Oops, Toni, I'm getting quite a bad echo.
I'm going to echo myself.
Okay, is that better?
Yes.
Yes.
Thank you, Jack. Yes. One of the things that that Jack and I and others have been talking about is developing a research agenda that would be parallel to the action agenda that comes from the Global Action Plan on Healthy Aging. And one of the things that, and I think this comes in probably 2 or 3 areas. One is, and I would ask people like Fernando, for example, what are the knowledge gaps around what the World Report on Aging and Health called intrinsic capacity? Do we need to know more about physical health, mental health, or do we have the evidence? And that we need now to think more about how contexts make a difference. So there's one piece. I'll just mention a couple of others, and I'd appreciate your response, Fernando. The other is the one that Ken raised, which is, he says we've done a massive ecological experiment. Well, in effect, I think we don't know enough by region, by country, in different places, how contexts of aging, communities, policy, families really do make a difference in how people live their lives. And I think finally the pieces around social exclusion and how these develop over life courses is another big piece. But one of the fundamental ones, and Fernando, maybe you can help, or Mario if he's still there, is there more we need to know about those basic characteristics of older people there, particularly their physical and mental health? Toni, I think you're on mute.
I'm inviting Fernando. Mario, did you want to respond?
Yes, we know knowledge about all our people. We need to investigate, we need more work about our situation. Latin American is a heterogeneous population. Huh? It's very different. I was thinking when I listened the Asiatic presentation, what different is Peru from Mexico, from Brazil, from Uruguay, and the isolation, it was very different. And I can talk about my own country. My own country was different, the epidemic of COVID, because we had a good health system, we have a good social development, we have infrastructure, and at the first time, our culture was facilitator, facing for the best thing. We must to study to know our reality in Latin America. I don't know if you understand me. Sorry by my bad English.
No, I think so.
Gracias, Fernando.
Yes, thank you. Thank you for your comments. I'm just going to try to get in a few more questions, and people can comment along the way because we're running out of time. So Alexandra Stepanuk speaks to Julie's slides, and he asks on the slide before India and shelter, when mentioning ingredients for healthy aging, did not mention housing. What is that situation? To me, a person in the UK, the words for a person in the UK, the words geriatric ward strikes terror with their associations with the lack of dignity and respect for older persons. Finally, things in Singapore and Taiwan are re-aging are inspirational. And for Isabella, I thought Uganda has enshrined palliative care in their law. Is this not working? Julie, Isabella, would you like to, any thoughts?
I'll speak first about the housing, and yes, housing is incredibly important. I think it's part of the environments for healthy aging. If you think you've got the person and their housing, their social environment, their built environments, their neighbourhoods, etc., and the policy environment as well. So housing is incredibly important. There's been quite a lot of work done that. I think particularly out of Singapore, there's a centre for sorry, I haven't got the right name, but there's a Centre for Technology and Design there. They have done quite a lot of work on housing for older persons, particularly in urban environments, and recently published a book on that, which I would be happy to share with people. And it's not just the housing, but how that housing connects to the rest of community and how that enables people to participate, to move around their communities and to meet their needs. So that's important. I think geriatric wards probably do strike terror. I think nobody wants to be in a geriatric ward, but also I think if we're thinking about long-term care institutions, that strikes terror in older people as well. So somebody else asked about promoting care in the community, and I think most people, when they're looking at long-term care now, are looking at promoting care in the community, with the institutional care being reserved for the people with the highest and the greatest levels of need, who can't be cared for in the community. But I think we've got a long way to go before we get that community care right, and to recognise what that needs to be, that it's more than just some money for the people, that it's more than just having someone bring meals, it's more than just having someone help them with bathing. It really has to be enabling people and helping people to maintain their participation, their dignity, their social connections, as well as the more basic needs. Yeah, so that's probably enough for that.
That's amazing.
Thank you.
Yeah, maybe I can just attempt a response. But before I respond to the question, maybe just a quick reflection on the issue of community care and the importance of promoting community care over other forms like institutional care. I think it's important to realize that it really depends on context. There are some contexts, there are some living contexts, socio-spatial contexts that are simply not conducive for receiving and providing care. I've raised this example several times, you might have heard it, but I mean, one thing that struck us when we did research on the experiences of older people in slums, in urban slums in Nairobi, the sentiment that was conveyed to us very strongly was, we don't actually want to stay here. These environments
we don't want to age in place.
Sorry?
We do not want to age in place.
Correct. So it really, I mean, I think it's really important to bear that in mind, that community-based care approaches really depend on context and the extent to which they are appropriate and beneficial. The question about Uganda, I should say that I don't know specifically about Uganda and the legislation around palliative care, but I do know that there are a number of countries that have enshrined reference to palliative care either in their constitutions or in legal frameworks. But the problem is, as I mentioned, is that whilst these provisions are there in the frameworks, the allocation of sufficient resources and the development of implementation plans to put that into practice are what is missing. And I would hazard a guess that exactly the same is true for Uganda. But I have to say that I don't know that specific case.
Thank you for those comments. You know, we have about 10 minutes left, and I would like to, several of the questions and comments that I'm looking at, bring up the issue of the Convention on the Rights of Older People. For those of you who do not know this, convention is UN talk for a conference. So there, the idea is to bring together people who are who will focus on how to guarantee the rights of older people. Cynthia, I'm going to, as soon as I find a minute to a way to release you, I'm going to give you permission to talk if you'd like to say something. But Cynthia asked specifically if the regions that you represent would be willing to, interested in interacting with the UN Committee on Aging. Cynthia's one of the chairs, to promote this the Convention on the Rights of Older People, because it would be so helpful to link with members in your regions, in each of your regions, to interact with capital, with government, and then with ambassadors at the UN. Cynthia, did I represent your thoughts?
Yeah, let me just clarify. I believe I heard you correctly. Convention does not mean a gathering. Convention is like a Bill of Rights. There is a Human Rights Convention that was passed in 1948, the Universal Human Rights, but since then there have been others, such as that on the rights of persons with disability, the rights of children, and we feel very strongly that the rights of older persons, and particularly the COVID crisis, has absolutely brought that to the fore of the discrimination based on age for persons. So we are working hard, and there is an organization called the Global Alliance for the Rights of Older People. You can go on, just put that in a search and find it. We're working hard to try and bring together national governments, because that's who sends people to the UN, who then become the ambassadors, who then vote. But we need people in country, in capital, to be advocating, and who better than the people who work in aging in their countries. And so what you started off with of saying, what research needs can we fulfill? All the research that we can bring to bear of why it's so important to protect the human rights of older persons in this time of COVID and moving forward would be a giant step forward. So I just would offer, if we could possibly work together. There's our committee in New York, there's the committee in Geneva, there's the committee in Vienna. But GARUP is really coordinating from a national perspective, and then we in the committee in New York can reach out to the people, the ambassadors at the 193 member nations that we are seeking support for a political declaration on the human rights of older persons.
Thank you for clarifying that. And I must say that I suspect not a lot of you spend time reading UN documents, but, or though you're probably familiar with the SDGs, the Sustainable Development Goals, one of the things that's very impressive in the goals is when they mention specific groups, it's often groups that have had a convention. So they've had a declaration of a Bill of Rights, and so they're recognized. So that makes for, it makes for visibility and recognition of specific needs of older people. From your regions, do you think your regions would be willing to, would you be willing to connect the committee with people who would work with them to promote the convention? That's Cindy's question specifically. As regional chairs, you're supposed to answer me.
I'll answer you, Toni.
Thank you.
I think, well, one of the issues that we're facing in the Africa region is that the African Union has actually developed and adopted a protocol, which is, you know, similar in nature to a convention, a protocol to the African Charter on Human and People's Rights, specifically on the rights of older people.
Right.
And the problem, yeah, that was adopted in 2016. And so far, less than a handful, I think it's 3 countries, have actually ratified that protocol. So there is an effort, an advocacy effort going on at the moment to try and get more member states to ratify the protocol. Once 15 have ratified it, then it enters into force. Without it, it has no effect, it has no impact. So I think there are possibilities of trying to connect those advocacy efforts around the African protocol with what's going on at the global level with the push for a UN convention. And I'd be happy to see if I can make the connections. And who knows, perhaps there is synergy in that. There's the potential for synergy with these two separate or two parallel advocacy endeavors. It's worth exploring. So yes, Cynthia, I'm happy to try and see where the connections can be made or to help forge those connections.
Julie.
Yes, so I've been going to the last few open-ended working groups on aging at the UN in New York. Didn't go this year, obviously.
Me neither.
But I'd say one thing to Isabella, in that last year there was quite a large contingent, or larger than usual contingent, of civil society representatives from different parts of Africa. And that was fantastic to see. And they were very engaged and enthusiastic. So that was a very positive thing. And yeah, there's a number of people who've been going. I think, can you remember, Toni, what year we're up to? I think we're up to year 11 or 12 of the discussions. This is a long process. And I think the thing to bear in mind is that part of the process is part of the action, because when you're having these discussions and you're highlighting what the issues are, and not even so much what happens on the floor, but more what happens in the side events. Yeah, Toni's rolling her eyes about what happens on the floor. But what happens in the side event is really, really important. Then I think what we do in between times, what we take back to our countries, the communications that we have with our political leaders and our representatives, I think they're really, really important. So this week I had a meeting with one of our members of parliament who runs the Parliamentary Friends of the UN to talk about the lack of action on the Convention on the Rights of Older Persons. So it is what we do, and it is the discussions we have in the meantime, and it is the awareness raising and the looking at where the gaps are, because that's the argument we have to make, that there's gaps, that people aren't protected by the Universal Convention on Human Rights, that there's special protections that older people need.
Right.
I'll just say quickly, I think it's a great idea. Sorry, I tried to answer your question before I was muted. I was talking to myself, but I think it's an excellent
Well, that's great. Cynthia's in New York, so she can, she has some better access to Americans, but I think we need more, and you have better access for sure to Canadians. Fernando and Mario, any thoughts on this? You're muted, both of you. But I see your lips moving.
No further comment.
Is there any interest in cooperating or communicating? So, okay, so that's the comment we need, yes, okay. And Fernando, what about you?
Well, I'm working hard here, and I see one question from Laura Machado, how the COMLAT can work on the country, on the region. I think we need to involve the politician people and the government, because Latin America is very unstable. Huh? We had other problems.
So are we here in the United States, or so it feels. Okay, Well, I'm watching the time and we're out of time, but that sounds to me like I have your permission to give Cynthia your emails and she will follow up with you. And you can have hers. She's written it in the chat box if you'd like to follow up with her directly. So I thank you to all the people who joined us as attendees, and I thank you as panelists. I think it's very helpful, insightful, informative, and it's very clear we have our work cut out for us. But we're in good hands if we're in your hands. Thank you, and stay with us as IAGG goes forward and tries to help with achieving a healthy aging in the next decade. Warm regards to all. Stay safe.
Thanks, Toni. Thanks to all. Thanks to all.
Thank you.
Bye.
Thank you very much.